ensure that you capture your correct KMLTB registration number, so that we can be able to report for you. Remember, this session is KMLTB accredited, and therefore it will be able to attract 3 CPD points. And for us to report the CPD points for you, your details must be accurate. So don't be in a hurry. Just take a minute to confirm you've written your correct name, your correct email address, your correct ID number, and your correct KMLTB registration number. So once again, ensure that all those details that are required are correct, so that we can be able to auto-report for you. So at this point, we are very glad to have all of you on board. I can see many colleagues from across the country, from Nairobi, Eric Omondi, from Nyeri, Ambrose, and many of you from Meru, from Baringo. Yeah, we are very glad to have you. Grace from Nandi County, Mary from Kiambu, from Kisumu, John. We are very glad to have all of you. So at this point, as you know, is that we shall be taking questions or comments at the end of this presentation. So that is exactly after the presenter or our speaker is done with this presentation. We shall be glad to take your questions or comments. So at this point, allow me once again on behalf of Lab Medicine Society of Kenya to invite all of you to today's webinar, the 20th of August, 2025. And we have a very exciting webinar on the role of CD4. I hope you have been able to see the poster with you. And we are excited today to host this webinar. It's understanding the role of CD4 count in HIV diagnosis and management. So we know that CD4 plays a great role, and we know that we are involved in the day-to-day testing, or of whether you do it on site or you refer samples. So we are glad to have you here, and I just want to invite all of us, and hope that we are all going to enjoy. So our speaker is we're privileged to have our speaker today is Wycliffe Achola, and Wycliffe Achola is a medical lab officer working with the Aga Khan Hospital in Kisumu. And Wycliffe holds a bachelor's degree in medical lab sciences, and Wycliffe is also certified with the American Society for Clinical Pathologists. And welcome, Wycliffe, from where, if you can hear me, so that we can just start and enjoy the presentation together. Once again, we're excited to have everyone on board, and we shall take all the questions and concerns. You can write them on the part of Q&A, so that we can be able to read them at the end of this presentation. Thank you, Wycliffe, and over to you.
Thank you so much, Fred. I hope I am audible enough. Can you hear me?
Yes, you are.
Thank you. So without any further ado, I don't think whether I need to introduce myself again. This is my third presentation with LMSK, and it is always a pleasure. So today we are going to discuss about the role of CD4 count in HIV diagnosis and management, with a focus on latest trends and guidelines. The presentation highlights the central role of CD4 cells in HIV pathogenesis and care. This aligns with WHO and our country's guidelines, and will explore clinical, diagnostic, and public health implications. So this presentation is just a comprehensive review that will highlight the latest trends and guidelines that relate to HIV management globally and regionally. The key focus is on CD4 cells, which are a subset of T helper cells that play a critical role in the human immune system. As we are all aware that despite the progress in HIV prevention and treatment, recently the disease continues to pose significant global health challenge. And the impact of HIV/AIDS is particularly severe in sub-Saharan Africa, where the prevalence is the highest. As we are all aware that while the initiatives like PEPFAR have played a critical role, recent funding disruptions and policy changes, such as those related to USAID reforms, threaten to undermine these gains and may hinder progress towards the goal of ending HIV/AIDS as a public health threat by 2030. So this is a wake-up call for us as a country, as a region, that where we are at the moment, we really need to think of changing the conversation towards depending nearly at zero on external aid to manage HIV. So some of the objectives of our today's presentations include, we will understand the role of CD4 in the immune system. We'll explore HIV's impact on CD4 cells. We will examine diagnostic stroke management strategies. We will review our country's WHO and CDC guidelines in respect to CD4 cells and HIV management. So the objectives provide a structure for understanding how CD4 informs clinical and policy decisions in HIV care. So first things first, what is HIV? In a nutshell, HIV is a retrovirus that targets the immune system. We are all aware that it integrates into the host DNA through reverse transcription. Some of the ways that HIV can spread include blood, during sexual intercourse, that is in semen and vaginal fluids, and even in breast milk. So we need to understand that the HIV's retroviral nature allows it to hide in the host DNA, and understanding the transmission supports prevention and counseling. Let us look at the global burden of HIV. What are some of the key statistics? According to WHO, in 2024, it was estimated that 40.8 million people globally were living with HIV. There's still a challenge of new infection, but despite a decline, an estimated 1.3 million people acquired HIV in 2023. Approximately about 630 people died from HIV-related illness in 2024. Treatment coverage, 31.6 million people were accessing antiretroviral therapy in 2024. So this can tell us the importance of antiretroviral therapy in management and prevention of spread of HIV. Regional disparities, the WHO African region is the most severely affected, accounting for more than 2/3 of people living with HIV. And we belong to the sub-Saharan region, if you can remember our geography well. While some regions have seen significant decline in new infections, others are experiencing an increase. So this highlights HIV's disproportionate impact. Regional context is critical for resource planning and CD4 service delivery. I talked about that in the introduction. So let us have an overview of the immune system. We have normally the innate and the adaptive immune system, immunity in our bodies. And innate immunity is rapid and non-specific. And adaptive immunity is slow and highly specific. This is what most developments of vaccinations highly depend on, because the body adapts slowly and produces antibodies that are able to fight any future infection in general. So CD4 cells, which are a subset. Hello?
If your voice keeps breaking and it's not clear, so are you able to, can you just try and maybe move closer to your device and then you proceed? Thank you.
Thank you. CD4 cells coordinate immune response. Is that clear now?
That's better.
Thank you. So we have the T cells, we have the B cells, and the natural killer cells, which are involved. Just like I'd said, CD4 cells are a subset of T helper cells. The reason is because they express the CD4 protein, which is also in full known as cluster of differentiation. So CD4 cells activate other immune cells, which include the cytotoxic T cells, the B lymphocytes, and the macrophages. So let us delve deeper into the function of CD4 cells in immunity. Just like I had mentioned, as I've just mentioned in the previous slide, CD4 activate macrophages, B lymphocytes, and cytotoxic T cells. It also produces the T cell growth factor, that is interleukin 2, and IFN gamma, which is for macrophage activation. CD4 cells regulate the immune memory, and normally the normal range varies from 500 to 1,500 cells per cubic millimeters of blood. We should note that CD4 cells vary with age, sex, and time of the day. And CD4 to CD8 ratio is clinically relevant, and the normal range is always 1 to 3. And we should always know that a ratio below 1 is indicative of suppressed immunity. A single CD4 value is less useful than trends. The ratio helps indicate the immune balance or chronic activation. CD4 count of less than 500 indicates suppressed immunity, while CD4 count of less than 200 is critical. So let us go back again to HIV pathogenesis overview. This will help us to understand the role of CD4 cells in HIV diagnosis and management. So generally, the HIV entry into the T cell, it will bind to CD4 receptors, which are just on the outer layer of our lymphocytes. And it will also be helped by CCR5 and CXCR4 co-receptors. So after that, there will be fusion and reverse transcription. That's where now the process begins of integrating itself into the host cell. After the reverse transcription, there is integration, and the integration will lead to production of provirus, and the provirus will now replicate into other cells which are now infected. So each stage of HIV life cycle is a potential drug target. This explains why multiple antiretroviral therapy classes of drugs are used. So let us understand HIV and CD4 depletion. So HIV depletes CD4 by directly killing the CD4 cells. It depletes CD4 by bystander apoptosis, which is in simple terms the death of nearby and exposed cells. Just by the fact that they are nearby the exposed cells, there's a high possibility of their death. Then immune exhaustion. And we should understand that only a fraction of CD4 cells is lost due to direct infection. Chronic inflammation plays a major role in immune collapse. That is why sometimes we can experience a case where we do CD4 count in acute infection. The CD4 is just okay, maybe 700. Then if this person is not put on treatment, after a year or two, the CD4 will drop to even less than 100. So very fast, let us understand the stages of HIV infection. So we have the acute infection, which is the initial stage occurring within a few weeks of HIV infection. Symptoms include fever, swollen lymph nodes, sore throat, rash, muscle aches, and fatigue. The symptoms can be mild and flu-like, making them easy to mistake for other illnesses. And we should note that at this stage, CD4 count is either normal or high. Then we have the clinical latency, which lasts for years or even decades. Symptoms are typically minimal or absent during this period. The virus continues to replicate, but at a lower rate compared to the acute stage. During the latency, CD4 count will gradually decline. Then now we have the AIDS, which is the most advanced stage of HIV infection, characterized by severely damaged immune system, making the body vulnerable to OIs and cancers. These are opportunistic infections and cancers. A CD4 count below 200 cells per cubic millimeters of blood, or the presence of AIDS-defining conditions are used to diagnose AIDS. Without treatment, survival in the AIDS stage is typically around 3 years. ART can effectively suppress the virus, preventing progression to AIDS and allowing the immune system to recover. Each phase has distinct risks and intervention points. CD4 count defines AIDS progression clinically. We should always note that. So what are some of the clinical implications of CD4 loss? So the first one is opportunistic infections. And I've just given 3 examples. We have pneumocystis pneumonia, or PCP, which is normally common in CD4 less than 200. We have toxoplasmosis less than 100, and CMV retinitis less than 50. The second one is poor vaccine response, increased risk of cancer. And we know one of the common one is the Kaposi sarcoma. We have CD4-based risk guides. The CD4-based risk guides prophylaxis and clinical suspicion in symptomatic patients. So let us understand or remind ourselves about HIV testing and diagnosis. So currently, I know in advanced labs, we use the 4th generation tests, which detect both HIV antibodies and the P24 antigen. And it is always confirmed by PCR. So according to CDC guidelines, opt-out testing is always guided by the trends in the numbers of HIV infections and the efforts to prevent it. So normally patients are informed that HIV testing will be performed, and it will be conducted unless they explicitly decline. So this helps in identifying the cases of those positive cases that are still in acute stage, so that treatment can be started immediately and preserve the CD4 cells. So early diagnosis enables earlier antiretroviral therapy and is better for the CD4 cells preservation. So what are some of the CD4 cells testing methods? So the gold standard is flow cytometry. We have point of care tests, which have expanded, which access has been expanded with the programs that support HIV management and care. And one of the common ones is PIMA, ALE. And the interpretation of CD4 testing must be done in context. So different methods may vary slightly. And just as I have said, clinical context matters a lot. So the normal range, as I had previously said, is 500 to 1,500. Borderline is 200 to 500, and less than 200 is severe. So the use of the ranges to try is used to triage urgency, and decline below 200 indicates the need for opportunistic infection screening and urgent antiretroviral therapy. So we should always remember the clarion call that was introduced some years back by the programs that support HIV testing and testing, treatment, and care, that we should always test and treat. Initially, patients will be tested, they will turn positive, CD4 counts will be will be between maybe 500 and 1500, and they were left to go. But nowadays it is test and treat, so that we can suppress the viral load. So let us look at CD4 cells versus viral load. Just like I'd said, CD4 cells are an important immune marker. They help in getting a clear picture of the immune status of a patient. Viral load is a replication marker that is tested for, which are always used together, which will show patient risk and antiretroviral therapy success in patient who has already started treatment. So both are essential for HIV management and care. So monitoring of CD4 and VL, according to WHO, if the CD4 count is stable, then 6 monthly for patients who are on ART is recommended. It is recommended to be more often if CD4 cells is less than 350 or deteriorating, or annual if very stable. So monitoring must balance clinical benefit versus cost resource limits. Because we know that if it were not for the support maybe we get from our partners, then most of us will not afford even a CD4 cell count test. So let's talk about rapid antiretroviral therapy initiation. Start immediately, just like I had said, test and treat. We should not delay for CD4 cells to decline or for resistance. This helps in improving survival. Delaying antiretroviral therapy worsens the immune loss. And earlier starts preserves the CD4 cells. And for those who work in HIV care, management, and treatment settings, know that the antiretroviral therapy always combines more than 2 or 3 drugs. So we have the NRTIs, the NNRTIs, we have the PIs and the INSTIs. So I'll just briefly talk about the classes of the drugs so that we can remind ourselves about their mode of action. So the nucleoside reverse transcriptase inhibitors, they interfere with the reverse transcription process, which is crucial for HIV to convert its RNA to DNA. And some of the common examples include TDF, which is tenofovir. We have FTC, emtricitabine, and abacavir, that is ABC. Then we have non-nucleoside reverse transcriptase inhibitors, which are similar to the first category, and they also target reverse transcriptase, but they bind to the different site on the enzyme. The examples are efavirenz and rilpivirine, RPV. Then we have the PIs, which are the protease inhibitors. They block the protease enzyme, which HIV needs to assemble new viral particles. Without a functional protease, the virus cannot mature and infect new cells. So the examples are atazanavir and diuranavir, that is ATV and DRV. Then we have the integrase strand transfer inhibitors, which prevent HIV from integrating its DNA into the host cell. And which is a very necessary step for the virus to replicate. And one of the common examples is DTG, dolutegravir. So the main goal is to suppress the viral load and to increase the CD4 recovery. So when the viral copies are down, the CD4 cells are stabilized, the patient is good to go. So let us talk about antiretroviral therapy and CD4 recovery. Like I've just initially said, suppression increases the CD4 rise. Early ART is equal to beta gains. Long-term ART is equals to better prognosis. There are people who have lived with HIV for more than 30 years, more than 20 years, because they have adhered to the antiretroviral therapy. And when viral load goes above 200 copies per microliter of blood, this indicates virologic failure. When immunologic failure is demonstrated by no CD4 rise. So adherence and resistance testing is very key. So let us understand about advanced HIV disease, or AHD. So this occurs when CD4 cells are less than 200, or the WHO stage 3 or 4. The mortality rate in AHD is very high, requires screening and retroviral therapy. So in this stage, CD4 testing is very critical to detect, and also rapid ART, TB, cryptococcal antigen screen also helps in saving lives. So we have TB screening, we have cryptococcal antigen screening, treatment, and cotrimoxazole. So evidence-based package helps in cutting early mortality in AHD. So even in AHD, CD4 testing is still very important. So what are some of the country's guidelines in AHD? So we screen when the CD4 is less than 200, emphasize on linkage, follow-up, community support, which is very essential. And it is very important to note that our national guidelines echo the WHO guidelines. So we work as a team. So adding case manager, peer support for the people living with HIV is very important because we know that to date, stigma is still an enemy of HIV management and treatment. So we are going to look at CD4 in pregnancy, or PMTCT, that is prevention of mother to child. I hope my speed is okay.
Yes, Wycliffe, we are following closely.
Thank you. So in PMTCT, immediate ART is very essential regardless of the CD4 count, still echoing the importance of test and treat. We need to monitor CD4 for immune risk. We need to prevent maternal stroke infant complications. And we should always understand that high CD4 translates into better maternal outcomes. So PMTCT is most effective with early antiretroviral therapy. Pediatric HIV and CD4. So in children, CD4 norms vary by age, and children under 5 are monitored closely. But we should remember that antiretroviral therapy should be started in all HIV positive children. In this case, the use of CD4 percentage is very important, and all HIV positive children should be on ART regardless of the count. So in most cases, the children who have a percentage of less than 25% of CD4 cells require immediate intervention and should always be taken care of to avoid complications. So long-acting ART and CD4. So there are injectables like cabotegravir, there is which help in adherence. So the CD4 impact is still under study, and this is great for patients with adherence issues and monitoring CD4 during rollout. And I hope you're all aware that there's an injectable that is being rolled out in our country next year that will be charged, I think, approximately 6,000 per shot, twice yearly. That is PrEP. So CD4 and PEP/PrEP. So whenever someone is exposed or feels like is at risk of contracting HIV, or someone who is at risk should always be on PEP within 70, or someone who is exposed should be on PEP within 74 hours, 72 hours, and transition to PrEP. So in this case, CD4 count will help in assessing the immune baseline, and initial CD4 count is very, very important, because you will find that this is maybe a person who had not tested himself or herself. So through screening, initial CD4 cell count, it would help in making clear clinical decision. So it is used in trends to decide long-term care needs. So we are going to talk about the CD4 and CD8 ratio, which I've said initially the normal range is 1 to 3, and an inversion value less than 1 indicates immune activation. So CD4 stroke CD8 ratio is a prognostic value. It helps in giving a picture of how the patient is doing, including recovery potential and any chronic activation. We should always remember that patients who are on care should be on continuous monitoring, because they need support both socially, clinically. They need support even from us as the lab team. So it is always a continuous journey, and the main goal is to reduce the cases of new infection, to manage those who are already on care, so that we can prolong their lives. So I know there's a phrase that is common to most of us: U is equal to U. So we know that undetectable viral load translates to untransmittable HIV infection. So patients who adhere to treatment are unlikely to transmit or to infect others. That is why there is strong call for us to, for those who are in the clinical settings, for us as the lab team, to make sure that we are giving quality results that can help in making clinical decisions that will help the patient. So viral suppression benefits CD4, and it also reduces inflammation. There's a pictorial here of high CD4 T cell count and a reduction in viral load copies. So always remember U is equal to U, and you test and treat. So what are some of the steps, or what are some of the gains that we've had in HIV cure research? We know that this is a continuous process. There have been some developments lately. There's some researches that target the CD4 reservoirs, and one of them is the clustered regularly interspaced short palindromic repeats, whose main target is the latent stage. So this is a technique that tends to reactivate the dormant virus from its latent reservoirs within the host cells, making it susceptible to antiretroviral therapy and leading to functional or sterilizing cure. So this is still research that is in progress, and we know that one day there will be a breakthrough. Nobody knew that one day we will have an injectable HIV PrEP. Early antiretroviral therapy preserves immunity. Models based on cohort studies have indicated that the rate of sexual transmission during early acute infection is 25 times as high as that found in chronic or established infections. Acute infections then, despite its short duration, can account to 10 to 50% of all new HIV infections. So this is very important for us as the lab team, as a whole system, that early detection is very significant in public health advantages. So someone would be HIV positive, infect another person without even him or her knowing that he is infected during the acute stage. So latent CD4 cells are a cure barrier. Interventions aim to shock and kill or silence the virus. That is the technique that I've just talked about in the first point there. So what are some of the CD4 testing limitations? Variability by time. There is co-infection. Sometimes when someone is even down with some strong flu during the SARS-CoV, CD4 test, the CD4 cells will go down. So it is always good also to do clinicals, to do HIV tests, so that we would help in achieving our HIV goals. The cost. CD4 testing is very expensive. It can look cheap to those who get the services free of charge because of the programs that support it and even the country's efforts. And they still need for infrastructure to enhance CD4 testing. So despite these limits, CD4 cell count is irreplaceable for advanced AIDS, HIV disease. Point of care tools help in low resource settings. So let us remind ourselves about the role of viral load monitoring. It's a direct treatment marker. It's always used in follow-up, prioritized by WHO, but CD4 cell count is still needed in AHD. So viral load is real time. You will test, know that now the level is below the detectable levels, but CD4 cell is cumulative. It will give the overall picture of the immune status of the patient. So CD4 informs planning. It identifies AHD burden, that is advanced HIV disease burden, and guides in program scale up. So what are some of the global or the countries guideline summary? So we have test and treat, advanced HIV disease care. We have long-acting prevention, like now the introduction of the injectables. Then we have the differentiated service delivery, which is DSD scale up, which is just a patient-centered approach that adapts HIV services to better the needs of people living with HIV and reduce the burden of the healthcare system. So this involves contact tracing, knowing the patient needs, the location, the frequency of visits, the follow-up, like the use of health promoters, strengthening the grassroots HIV testing. So it is a combined package that helps us in fighting HIV. So let us look at some of the case studies that will help us in just having a skeleton picture of the role of CD4 cell count in HIV treatment and care. So the first case study is of a late presenter, someone who presents late to the hospital with a CD4 cell count of 40. Drug is positive, TB screening has been done, and is on ART. So in 6 months, the CD4 cells shoot to 220. So this is just an indication of a case of a real world and advanced HIV disease success story, which showcases the importance of rapid and integrated care. So this looks like a case of a defaulter because it's someone who was an ART or a late presenter, but after intervention, the CD4 shoots, or someone who never underwent screening at all, and it is in the advanced stages of HIV. The second case is of an HIV positive pregnant woman with a CD4 cell count of 560. So initiated on treatment and delivers an HIV negative baby. This is a PMTCT success by a ICD4 suppressed PL. So we should always remind ourselves and know that antiretroviral therapy coupled with antenatal care is life-saving. The third one is a youth with a poor adherence, CD4 cell decline. So peer support increases viral suppression. So just like I said, that people living with HIV need an all-round support. So behavioral support saves life. CD4 decline detected issue early. So this helps also give us a clear picture of the importance of peer support in HIV management. So what are some of the challenges in CD4 management? We have supply chain gaps, like we had talked about the recent restructuring of some of our major partners or donors, staff shortages, stigma, which is still a major barrier to early testing. Even when the best tools fail without system, stigma remains a major barrier to early testing. So what are some of the innovation in CD4 monitoring? We have portable machines like the PIMA, POCT test devices, which can be used in the lower level facilities. There is AI here that can do prediction through modeling on the trends, use of SMS alerts on on just alerting the patient that should come for clinics. So in the improving technology access plus retention, low-cost diagnosis is a good indication of the future progresses in CD4 management. So what are some of the policy implications that we should take into consideration? We have investing in diagnostics. So they still need to expand diagnostics so that we can detect early, put on treatment, monitor, and prevent the ever increasing numbers of new infections in some regions, the sub-Saharan region being one of them. Supporting community care is very important, including CD4 cell programs in the universal health coverage. Strong systems is equal to better outcomes. So CD4 management, CD4 cell aspects deserves being a universal health coverage priority. So what are some of the summaries of the key points that we've just learned in the presentation today? CD4 cell count is critical in early care, guides on antiretroviral therapy, opportunistic infection, screening, global and national guidelines support use. Despite the focus on viral load as a key treatment marker, we must all agree that CD4 cell count remains indispensable. So before I finish, I just want to add a few things on remember the CD4 receptors have some two co-receptors that support the integration, the entry of the HIV virus into the host cell. So we should remind ourselves that there are approximately 1% of people of the Caucasian descent who are homozygous for CCR5 co-receptor with a mutation that is known as CCR5 delta 32 mutation, which means that they lack the CCR5 co-receptor on their cells. So the mutation is less common or absent in other populations such as the Africans and East Africans. The mutation, which is a 32 base pair deletion in the CCR5 gene, prevents the CCR5 protein from reaching the cell surface. So this makes the individual with this mutation less susceptible to certain HIV strains. And as we are all aware that there's an injectable PrEP that will be rolled out in the country next year, which is known as lenacapavir, which is a first-class HIV-1 capsid inhibitor that interferes with the multiple stages of the viral life cycle. So its main mode of action is by binding to the HIV-1 capsid protein, disrupts its functions, including the transport, assembly, and release. So this leads to poor, improper production and failure to replicate. So some of the general references that I used to prepare this presentation include the CDC 2025, WHO 2025, Kenya NASCOP, UNAIDS 2024-2025. Thank you so much for your time. I hope I'm still audible now. I have kept time, but I still have 5 minutes, which is good. I'll take this back to Fred, but we can have time to discuss as professionals. If you have anything that you need to add, if you have anything that you can ask, any member can answer. I can answer so that we learn together as LMSK. Thank you, Fred. Over to you.
Yeah, thank you so much, Wycliffe, for a very wonderful presentation. It was quite clear, and I can see it has elicited a lot of comments and reactions from our participants. And at this point, team, I want to open it up for you. If you have any other questions or concerns, kindly you can do it on the chat box. There's no one shoe fits all. So if you feel you want to make your comments, or you want to make maybe some addition, you are free to just raise your hand, and I will be able to unmute you, give you the mic so that you can make your comments or even answer the questions that have been asked. As you can see, our chat box has been very open, and a lot of our colleagues have been able to write down their concerns or their questions. So, Omondi, I can see your hand is up. So just prepare your question, ensure that your background is okay. So I'll start with Eric Omondi, and then I'll go to Harriet Rono, and then Cleophas Imbosa, in that order. So prepare your questions. 1 minute is enough. If you want to just make your comment, it's still fine. So you make your comments, and then we proceed that way. So Eric Omondi will go first, and then Cleophas Imbosa, in that order. So for now, let me pick the first question on the chat box. And that is from, you can just confirm that you can hear me, Wycliffe?
Loud and clear.
Oh, very well. So the first question is from Michael Otieno. He's asking, kindly expound on how sex, age, and time of the day affect CD4. I think you want to say CD4 count. So, yes, Wycliffe?
Thank you.
Yeah, I can see the same question also has been asked, that an anonymous attendee is saying, what is the relationship of CD4 cells with time of the day? So maybe to you, Wycliffe.
So thank you so much, Fred, for this. Naturally, CD4 cell counts fluctuate throughout the day. They're typically lower in the morning and higher in the afternoon or evening. So this variation is a normal phenomenon, even in healthy individuals. So the magnitude can vary, but it is important of it when interpreting CD4 counts, especially in the context of HIV management. Remember, even stress subtly affects or reduces the CD4 cell count in our body. So it is not, as much as it is clinically significant, but it is something that we should always put into consideration, also for those who are in HIV in HIV treatment setups.
That's okay with Cliff.
Yeah, for sex, generally males have higher CD4 cell counts compared to females, but the range is not it is not so much variable. The variation of CD4 cell counts in children and adults is very important, as it gives clear guidelines on why we should use the CD4 cell percentages in assessing children who are exposed or even children who are already on care. So age is an important factor in CD4 cell count. Thank you, Fred.
Thank you, Cliff. That is clear. So I can see there are many questions, so I'll just proceed to the next question. And this is from John Otanga. He's saying, I didn't get the part of clinical latency. When you test someone who is in this stage, will the person be positive or negative? And then maybe I can add to another question, Wycliffe, if you allow me. Sylvia Sunda is asking, recently I had a client with a CD4 of 9 cells per microliter. What does that mean?
Thank you so much, Fred. I can confirm to you that patients in the latent stage of HIV should test positive depending on the type of the generation of the equipment used. As we all know that the current 4th generation ELISA test equipment, which test P25, P24 and anti-HIV antibodies, a patient who is on the latency period is already exposed. The body is already forming antibodies. The only thing that has happened is that the rate of replication is reduced. The viral copies are still in the host cell. So if you test, the results will be positive. The second question was about CD4 cell count of 9.
Yes,
Right?
yes, Wycliffe.
Yeah, so a CD4 cell, just like I'd said, a CD4 cell count of less than 200 is very critical. So I think clinical assessment is also important, and this indicates that the patient is in a critical situation because CD4 cell count is a reflection of one's immunity. Thank you.
Thank you so much, Wycliffe, for that. So I'll move to the next. This is from Benedict Washala. I see you have many questions. Wycliffe, you can just be keen. It's a long write-up. And then I'll move to another one from Ngeno Peter. So maybe you can just be keen. So Benedict Washala is asking, is there immunization against HIV in developed countries or still at the clinical trials? Lastly, what is the HIV percentage in Kenya currently? And are we on the right track when it comes to prevention and awareness? And I think he also says, thank you for the presentation. Be blessed. And still from the same Benedict Washala is asking, what is the difference between HIV 1 and 2 in terms of severity in infection and longevity after infections before symptoms can manifest in an individual? Since African continent is highly affected as compared to other continents, what are some of the efforts put up to develop our own ARVs now that we majorly depend on USA for funding and manufacturing of drugs? Lastly, apart from ARVs, what else can a patient take to boost his, okay, fine. Yeah, maybe Wycliffe, you have heard the question from Benedict Washala. Maybe you can just give a comment.
Thank you, Fred. So I'll start with the immunization part about HIV infection. Like we are all aware that the HIV infection research has been a work on progress. There have been major milestones, major breakthroughs, but we can confirm that there has never been any declared ultimate cure of HIV. So just like I mentioned that recently, there was a breakthrough on HIV injectable PrEP, that is pre-exposure prophylaxis, that will be rolled out in our country next year. I strongly believe that there have been clinical trials in the developed countries like the US or China. So this is a major breakthrough for HIV care, and it indicates the need for us to work as a team towards this journey of HIV management and care. The second one was on the severity of HIV 1 and 2. So the commonest is HIV 1, which causes most infections worldwide. HIV 2 is most common in West Africa. So HIV 2 is appears to be less severe compared to HIV 1. And we also know that there's another type of a retrovirus known as HTLV1, that is human T lymphotrophic virus, which is less common but can also cause a serious disease. So to just answer my colleague is that HIV-1 is the most severe one. The demographics is it is found in most parts of the country, but HIV-2 is most common in West Africa. And I think in our setups, once in a while, we have found cases of HIV-2 antibody, if I'm not wrong, here in Kenya. The third one was about what? Remind me, Fred. The major gains in our country?
Yes, please.
Thank you. Personally, I feel as a country, compared to 20 years ago, we are heading towards the right direction, save for, let me say, over-dependence or over-reliance on external donors, because the chunk of contributions in HIV have been supported by PEPFAR through USAID. So the recent restructuring are just a wake-up call for us that as a country we have the capability, we have the personnel, we as LMSK, we have the potential to improve HIV research together with the support from the country so that we can change the story and even start strengthening drug discovery in Kenya. So in terms of progress, I strongly believe we are heading in the right direction, comparing the gains today with the gains 20 years back in terms of even diagnostics. Remember 20 years ago, people will test for HIV and will even get their results after 3 months. So we are headed in the right direction with the advancement in technology, but we still need strong support from our country so that we can work as a unit to improve HIV care management and reduce to 0 cases of new infection. Yes, Fred.
Thank you so much, Wycliffe. Yeah, I can see there's a recurring question here on the storage time for CD4 samples. And I can see Christina Mondi has written something there that I can read to everyone. CD4 sample storage time and temperatures before analysis depends on the method or technique you're using. That's why it's key to pay attention to the manufacturer's instruction on the product being used. Some will specify, I think many of the manufacturers, that samples collected in EDTA should not be stored more than 12 hours at room temperature. I think that's very clear. So I'll move to the next question, Wycliffe, if you allow. This is from Ngeno Peter. In our facility laboratory, we sometimes encounter 2 HIV patients with the same viral load, but different CD4 counts. How do we explain this discrepancy to clinicians? And what management strategies should be considered for each patient? So if you got me, Wycliffe, I can add another one from, okay, maybe we can take that first.
Two similar viral load results, different CD4 counts.
Yes.
Thank you.
I think he's saying, Wycliffe?
Yes.
I think he's saying maybe patient A has a particular number of viral load copies and then patient B the same. But then when it comes to CD4, the counts are varying.
Yes, that is very possible because I strongly believe that HIV management and care is a package. Apart from antiretroviral therapy, their patients are advised on diet, they're advised on other ways of keeping themselves well. So remember, CD4 cell count is an immune marker. It indicates that someone's immune system is remarkably doing well or is on the decline. So depending on the kind of care, how the patient is taking care of himself, I don't really believe that if patient A has 100 copies of viral copies, 100 copies of the virus per microliter of blood, similar to patient B, then their CD4 count should be around maybe, let me say 300. So in my opinion, it is not a discrepancy, but it is something that can happen in our healthcare setup. Yes, Fred?
Thank you so much. I'll move to Wilfred. Wilfred Aria, thank you for your question. He's asking, since viral load is superior, okay, when does CD4 still matter? And should CD4 still be done routinely once viral load scale up is complete. And then I read the second question from Wilfred Aria. What if viral load is suppressed but CD4 stays low? What are the interventions to boost immune recovery in such patients? Thank you, Wilfred.
Viral load stays low.
Asking about viral load is suppressed, but CD4 still stays low. And then he's also asking about, okay, he's saying, when does CD4 still matter? And should CD4 still be done routinely once viral load scale up is complete?
Thank you so much, colleague. I strongly believe that viral load nor CD4 neither is superior, because the major gain here is about having a full picture of the patient's immune response versus the treatment marker. Remember, the viral load will just tell us that the patient is adherent to treatment, and there are no cases of maybe resistance. Yes, there are cases of where the viral load can be suppressed, but CD4 still remains low. And I'd talked about it in the slide here. In a case of immunologic failure, sometimes the immune system can fail. So the viral load can remain suppressed, but the CD4 does not rise. So this is when maybe there is need for extensive clinical extensive clinical care to determine any other causes apart from just the HIV that could be leading to the sudden decrease or rather plateauing of the CD4 count. So when viral load is stable, when viral load is let me say undetectable, according to WHO, monitoring of CD4 is still important, but can be done in intervals of either 6 months or annually, depending on the prognosis of the patient. Thank you.
Thank you, Wycliffe. Maybe you can allow me to move to the next question. And this is from, okay. This is from Celestine Fuaga. He's asking, can we use refrigerated samples in testing CD4 results? I think he wants to say in testing CD4 count. And then how does time of testing affect CD4 results? And then Alfred Muye is asking, what has it that nowadays clinicians rely more on viral load than CD4 cells count in monitoring immune response? How true is this? Okay, maybe we can take those ones. And then Eric, if you can hear me, I want you to unmute so that you can go after this response. Yes, Wycliffe?
Thank you. I think we have talked about the time of testing, time of the day.
So Wilfred, I can see your hand is up. I'll give you a minute. You can unmute. Wilfred Aria, you can unmute, and maybe you can either give your comment or Yeah, you can give your comment. Wilfred?
Just a minute. Thank you. I just want to add something on the refrigerated samples. So ideally, just like a colleague said, samples put on room temperature should be analyzed within 12 hours. And refrigerated samples ideally should be analyzed within 48 hours, but not more than 72 hours, because the count might be affected by prolonged time of testing. Just like I had said in the presentation, from my findings during my preparation, the clinical context of the patient, or rather the progress of the patient, is very important in making a decision as a clinician on the importance of CD4 count in assessing it as an immunologic marker. So I strongly believe, and I know, that CD4 cell count is still indispensable immunologic marker because it activates all the other 3 immunologic cells, which are very important in fighting infections. And VL will always remain treatment monitoring. Remember, you can only do viral load after you put a patient on treatment for some time. That is when you will know whether the ART is working, or maybe someone has defaulted. There's the case of resistance. You want to reintroduce another combination. So CD4 all the day. Yes. Fred?
Yes, thank you for that. Maybe I can pick a comment from Abdifat Abdullahi. If you can hear me, Abdifat Abdullahi, kindly unmute and you can make your comments. Abdifat Abdullahi. Abdifat, if you can hear me.
Hello. Hello.
Yes, proceed. Yes, proceed.
Hello, Wycliffe. Hello, Fred. Hello, everyone.
Hello.
I wanted to ask a question like, there's a point you said U is equals to U. Was like, if the virus is undetectable, it is untransmissible. I wanted to elaborate for us that, like, the algorithm of HIV test of a 3-step test using strips, I use it and the person is negative. Does that one finalize that the person I'm testing cannot transmit? Or will I go further, test like PCR, ELISA test, so that I can conclude it is untransmittable? I wanted just to know between those two. Thank you.
Thank you so much, Abdifata. I think I have pronounced it well.
Yep.
Remember, the context of U is equal to U is on patients who are already on care. The aim of putting patients on care is to suppress the viral load. And by so, the CD4 cell count will skyrocket. And this will mean that the immune system will be stabilized. So in combination with other preventive measures to avoid, or rather to reduce, the number of new infections, studies have indicated that patients who are virally suppressed are unlikely to transmit the virus to others. This is because of the below detectable levels viral copies in their blood. According to the algorithm of testing, once a patient has been tested negative, it should be reported as negative. I hope that that is the case. So using the rapid kits, unless in cases of indeterminate results, or rather invalid results that might require other interventions. But we should know that even by testing using the rapid kits does not mean that someone is not exposed. And maybe subsequent testing are very necessary depending on the risk and the exposure of the patient. Thank you.
Thank you too.
Thank you. I can see there are many concerns on this subject, and maybe, yeah, this tells that maybe we can have more sessions to just capacity build ourselves and to also be abreast on the current practices and the current guidelines. So for sure, we may not be able to handle all the questions. Remember, we are over 1,000 of us here. So the questions are so many. But Aria, if you can hear me, you can unmute and make your comments. Aria, Wilfred. Wilfred Aria, you can unmute. Wilfred, you can unmute and make your comments. Okay, very well. Proceed, Wilfred. You are unmuted and you can proceed. Wilfred, you are unmuted. You can proceed to make your comments. Okay, so is unable to speak. Joseph Onyango, you can unmute and talk. Joseph Onyango, proceed to unmute yourself and make your comments. Simon, you are next. Joseph. Okay, so Simon, unmute. Simon Kihara, you can unmute and make your comment. Simon.
Thank you very much. And my contribution to this is that, as the presenter has said, the ARV work towards suppressing the virus, and the CD4 in this case will be increased. My addition thing is that the CD4 also will be affected by the nutrition. The ARV by themselves may not increase the CD4 count. And also the CD, there is a CD8 usually in the bodies, which are the cytotoxic and work against the antigen presenting cells that are the CD4 cells, lowering them. Yes.
But I think it's from their end.
Thank you, Simon, for the wonderful addition and for the wonderful comment. That was great. Aria, I can hear you talk. Can you make your comment, Aria Wilfred? Wilfred? Okay. Wilfred, your hand is up. You are unmuted. Can you make your comments? Joseph Onyango?
Yes, can you hear me?
Very well. Proceed.
Okay, good evening. Okay, I'm having a question regarding the you to you thing. Maybe I'm using a system whereby the lowest detectable limit for my system is 200 copies. Then the other one is using 50 copies. Okay, when is the cut line for now U to U on these two scenarios?
Thank you, Joseph. Wycliffe?
Thank you so much. I strongly believe that undetectable levels of the viral copies in most technologies should be less than 20 or less than 40 or 20. If I'm not wrong, someone can correct me. So it is because the equipment, the machines have cutoff. But if the copies are less than 40 or 20, it will just detect as LDL or below detectable levels. So I don't think whether 200 or rather 300 would be undetectable. So it is always either below 20 or 40. Someone might correct me. So the gains, or rather the campaigns that have always been out here with from our partners, from the research work that have been done, is it is just a way of in raising awareness on the importance of ART, and not just ART, but early ART, so that we can suppress the virus and reduce the cases of new HIV infection. Thank you.
Thank you, Wycliffe, and everyone. And Asad said that we have many unattended questions, and maybe time is not on our side, but I really want to say that it's been a very interesting presentation. And from all your comments, many of your questions are unanswered. And as LMSK, we shall plan to have more sessions so that we can capacity build ourselves. We commit even to bring these referral labs, the testing labs, where we take our viral loads, and maybe they will be able to shed some light on what they do and what the results they send to us means. So we've come to the very end of the presentation today. I'm sure we have not been able to answer all the questions exhaustively because of the questions were a bit many. But I think that is a good indicator that we were learning, and we shall be able to have more sessions so that we can just maybe be able to learn together. We can be able to capacity build ourselves, and also to be updated on the best practices and the current guidelines. So at this point, allow me to give a minute to our speaker, Wycliffe, to bring his closing remarks.
Hapa anaongea topic yenye nilikuwa nafanya all along ya HIV.
Thank you, LMSK. Thank you, team, for this opportunity. It is always a pleasure learning together with you. Just like I say, this is my third presentation. And apart from sharing whatever I have learned personally, I have also learned very many things. And together with the leadership, we'll still work together and even bring more so that we can progress as a society. So thank you once again, and may you have a wonderful evening. I just want to tell you that LMSK is the big thing today, not even tomorrow. We just need to strengthen it. We need to join. We are so many techs. My registration number is above 10,000. So it means and I registered around 8 years ago. So it means that we are over 13,000 or even close to 20,000. So if we can come together as a people, as professionals, we can make LMSK greater than it is today. May God bless you. And we would like to have even more presenters from you team so that we can learn together. I tell you, it is a great experience presenting and also learning at the same time, because we only learn by teaching and we teach by learning. Thank you.
Thank you so much, Wycliffe, and everyone who found time to log into this webinar. And on behalf of LMSK, it was a pleasure hosting you, and see you next time. Have a great evening.